So, you know, I'm a rather special breed. What we're going to do today, can I? Yes, you'd better do it. Next slide. Can we have half the lights turned off? And the other thing, I've been brought up forceps, as like all my generation was, and you know, I can still do a mean Keelan's if in fact you can't find a vacuum there. So it's not a question of vacuum at the expense of forceps. That's not what I'm about. I'm about, if you are going to pick up one of these potentially lethal devices, then I think we should be doing it maybe correctly. Now, whether what I'm going to tell you is the correct way or not, I'm not sure, but I've certainly been looking for the correct way for 40 years, or more now, 42 years. And a lot of that has come from Papua New Guinea. We tend to look down on these places. When I came back into, you know, this type of environment where it's centres of excellence and so on, I had great difficulty in saying, well, you know, you'd be surprised what a high service and standard you can give. And I think Dr. Peters has touched on a very important point. If you weren't, if not just a matter of trust, but if you weren't capable, that really was sussed out fairly early in the piece. And so a lot of that skills, or those skills that you pick up, have stood me in good stead. Unfortunately, the high tech that we've now got in that you're subjected to weren't there in my time, and that is great in one way, but it really results in de-skilling in other ways. So that's my little philosophical introduction. But what we're going to do today is this, and the key word is this. We could talk about vacuum delivery, and don't think that the attitudes in the United States are all that different from in my country. Everyone says, oh, we have a great medical legal problem in this country. Well, I can tell you, we're catching up fast, and soon we're going to be teaching you about medico legal things. So the problems are the same. Perhaps emphasis shift around a little bit where you're practicing, but the technique is the same wherever you're practicing. It does not change. It's the clinical circumstances and maybe these other issues that are not medical, but we find ourselves thrust into it time to time. They're the things that change. They're the things that make a procedure more complex or less complex, not the technique. And you know, I spend some of my spare time, and you know, it's certainly strained my 40-year marriage and so on at times, that, you know, I'm trying to develop women and the essential parts of women and the essential parts of, you know, of babies, and the maybe simplifying or devices. But now I'm focusing on technique, because that is what's universally badly done. So let's not waste any more time, because I want to work through this very quickly, and those of you who are staying, we can work on the model and we can simulate the technique to a high degree of realism on this. So come with me. They tell me, you, as I said, that you're a highly intelligent group, so I don't have to you know, tease things out too much. So if you're not sure of what you see in the two-dimensional world, a lot of the things I say here will be easier to do rather than for me to describe. But if I don't describe them, you won't know what I want you to do. In fact, I've simplified the approach to technique. So here we go. This is what you're going to do today. There'll be a couple of important principles. This is probably the most important of what we're going to do today. So you need to know about the concept of the flexion point. Well, you need to know position to get the flexion point. Once you get the flexion point, you're going for that. Position becomes secondary. And we've been programmed into thinking position. Well, I want you to step outside of your comfort zone a little bit. Once you get the flexion point and you're in neat position, I'm not saying it's not important, but you do that. And then there's something that I haven't been emphasizing until relatively recently. I bring it up, but this is the concept of the midpoint. We'll come to that in a moment, because both of these are necessary. Well, this one in particular is necessary for you to place the cup. And if anybody feels, and I've got some wonderful quotations, you know, you need to be a relative of Einstein to do a forceps delivery because you need application, whereas anyone can do a vacuum delivery. Well, it ain't like that at all. I think, you know, the application of the device is just as important for a vacuum as it is for forceps. I say at least as important, but I'll let you mull over that one. Every vacuum delivery that you will be required to do is composed of 5 steps, 5 basic steps. If you get those steps right, and after you say your prayers at night, if you then recite these 5 steps so that you keep remembering them, you'll find that it'll stand you in good stead. So we'll define them and describe them shortly. But whether you're doing, and really, if you say, I don't do mid-pelvic deliveries, that's up to you. But whether you're doing a mid, low, or outlet delivery, whether you're doing an anterior, transverse, or posterior delivery with slight or a lot of deflection or slight a lot of asynclitism, you go through those same five steps. You might have to vary or adapt your technique a little bit to the circumstances, but that's all you're doing. So don't add steps that are unnecessary to it, and there are lots of them. We all get good ideas and say, oh, let's do that. We test them, they don't work, but we still do them. So much for evidence-based practice sometimes. Then I think if we're going to achieve the recommendations that your college is imposing on you and my college on me and the British College and the Canadian College, then we really need to re-look at vacuum, because a lot of the recommendations for so-called safety we can't achieve. So they're asking you to do the impossible. And then if you don't achieve the impossible, you get caned for it. So I think we've really got to rethink the whole, we've changed, I've just mentioned, the whole of obstetric practice, let alone gynecological and all these other, imaging and so on has become so complicated. So we adapt our own training systems, we adapt all sorts of things to that, but we expect vacuum delivery to remain the same, or your approach to it. Well, we've got to adapt it. And one of the things I think we should do, which will become clearer, is divide vacuum as we've done with labour. We divide it into different stages and stages into phases. And we really need to divide vacuum into a descent phase. I am speaking rather quickly, so if you don't understand my brand of English, then come back at me, because I want to move on to this as quickly as we can. A descent phase and a pelvic floor and perineal phase. Because in the descent phase, this is where the risk is to the baby, but it's not the most complicated phase. It's here when the head hits the pelvic floor and perineum, where cups are popping off, and sure, it's not good for baby if you keep doing that, where the resistance is greater. So we've got to realign our thinking in that regard, because we've grown up thinking, well, everything up here is bad, everything down here is good. Well, the demarcation isn't that clear-cut. And I hope to at least, if not convince you, throw in a few things that might get you thinking. There's a lot, even on the technical aspects, and we won't have too much time to actually go down that track, that maybe, you may have some, for instance, should we be reducing pressure between contractions? Does anybody do that? I mean, level 1 evidence from this country has certainly given me evidence for not doing it. I've never done it, but I've now got evidence for not doing it, and yet you'll still find people who are doing it. So it adds another step, unnecessary, not beneficial, and not harmful to keep the pressure up. So don't do it if you're not doing it, and I'll give you the evidence if you come out of Beaufort. He did a wonderful study. Episiotomy is an issue which I don't want to spend too much time on today, but let me just give the bottom line and say you do an episiotomy if it's necessary, just as you would with a normal delivery. I worry when people say, I do a vacuum because you don't have to do an episiotomy. I don't know where that came from, but it's certainly not good practice. You do it if it's necessary, but if you don't do it, for goodness sake, give time for the perineum to distend over the head, just as you do with a normal delivery. When you see cap it and if the baby's okay, and if the mother's pushing and she doesn't want an episiotomy, you would allow any number of pushes for her to deliver that baby. And yet when you see the cup in the introitus, well, I've even had one attending last week say to me, I want that baby out in 15 seconds when I see the cup. Well, that's in general, that's not possible. And of course, why do cups come off? Well, we'll talk about that in a minute. But they always virtually come off when you can see the cup. It's the most resistant part of the birth canal. So if you say to me, I only do low vacuums, you haven't escaped the most resistant part of the birth canal. or the level of the birth canal. And then we come to rotational and non-rotational vacuums. The technique is exactly the same for vacuum, for those. It's obviously the clinical circumstances that might be making a head posterior or transverse. But, you know, we're scared of that, and our guidelines say, whoa, don't try to rotate. Well, if the technique's the same, and nature rotates, doesn't it? Well, let's go to the next slide. It'll bring us up. Here's internal rotation as part of the normal mechanism of labour, without a vacuum or without forces. And I think the vacuum has suffered at the expense of forces because we've got, you know, the Keelan's rotation requires extra skills and above the non-rotational procedures. Whereas the vacuum, I'm trying to emphasise it, and because it's certainly not a concept that's accepted, is an auto-rotation, just as you have an automatic rotation here as a normal mechanism of labour. Heads, we know, descend in anything but an anterior position, usually, but they come out usually, or most often, in an anterior position. So something has happened with the forces and counter-forces and the changes in dimensions and consistency of the birth canal and the propulsive forces, etc., etc. So the whole idea with a vacuum, then, if you have a problem here, we don't have the right to just stick a cup anywhere on the baby's head and overcome that resistance, or overcome the problem, with traction. I mean, that doesn't make sense to me. Why not correct the problem? In other words, if you've got deflection or asynclitism, we know, you know from the first day you came into this medical, the obstetric division, that if a head is flexed and synclitic, the optimal diameters are presenting. And yet when the problem is that the head is not deflexed, or when the head is not flexed or synclitic, we just disregard all these basic principles. This is principle number one. So do what nature is doing, and more often than not, you will improve your outcome by improving your technique. Next, thanks. Principle number two is these. There are two. One is the flexion point, and you notice if I can remember, I'd make that font the same size as that, because I didn't give it the prominence I think it deserves. The F, the flexion point, is crucial for vacuum delivery. If you're not sure what that is, then go and read about it. It's where the mento-vertical diameter comes out on the vertex. It's not at the posterior fontanelle. That's the other thing. We're used to thinking posterior fontanelle. That's where we get our position from, and so on. Well, in a flexed head, the posterior fontanelle is not the most dependent part of the head. It's 3 centimetres forward of the posterior fontanelle. Well, towards the anterior fontanelle anyway. It's always there. That's a key point. So you need to know position one way or other. And let's not get too bogged down when the position is not that clear-cut. Let's get right when it is clear-cut, because that's where most of the problems arise. We often use it as an excuse for our, well, less than ideal technique when things don't turn out the way that we want them to. So the flexion point is always there. If you can feel the posterior fontanelle, drag your finger forward 3 centimetres on the baby's head and hold it there, and that marks the flexion point. The point is, that's your longest diameter of the head, and the diameter at right angles to it, in which case it's this one, the suboccipitobregmatic, or the diameter at the other right angles to it, the biparietal, are the shortest diameters, and they're about 9 or 10 centimetres. So the head has a length of 13 or 14 centimetres, a depth of 9 or 10, and a width of 9 or 10. So you've got this rather large object that you're trying to get through, as I said, a birth canal that changes its direction and consistency and is bone and muscle and everything else. But when you, and so the way Rydberg, who first coined this phrase, this baby happens to have the flexion point marked, as I wish every baby had it. So there's the posterior fontanelle. There's the flexion point, 3 centimetres forward of that. Does anybody know the distance between fontanelles? Well, I do, because I went and looked. It's 9 to 10, so everything's 9 to 10 apart from this diameter. So we can actually touch that, and the whole idea is, as we said in the previous slide, is to place the centre of the cup. Because if that, when that is presenting in the direction of descent is the way Rydberg, who first looked at this, even though it's been happening for millions of years, Rydberg said if that is pointing in the direction of descent, then you've got your optimal diameters presenting, irrespective of position of the head. So if it's not flexed and synclitic, if it happened to be asynclitic and you're working from here, then surely you must correct the problem. So to get the optimal diameters. But that's fine and if you're pulling on a baby's head, surely you must be pulling on that point, because this is going to become the presenting part. You're pulling on it. It has to line up towards where you're pulling. And if you want doing a vacuum, if you want the best diameters, if you like, presenting, then you need to have that squarely over the flexion point, the center of the cup. And that's, we're coming to sort of the applied principles, if you like. So if you put the cup there and apply traction, then the cup is going to become the presenting part. If you have it anywhere but over the flexion point, if you have it over here and you pull, then it's going to tilt the head that way. And if you have it too far forward and you pull, it's going to tilt the head that way, giving you larger presenting diameters in one or more planes. And if you happen to put the cup too far forward and too far to the side, you're going to do that, which is going to give you less than ideal diameters in all planes. Unfortunately, the majority of vacuums that are done today, well, the cup is applied in just that position. The minority are placed over the flexion point. So that's step number one. If you do that, you'll find that a lot of the other problems will disappear. Now, the other M point is, or the midpoint of the head, I call it. Theoretically, it should be the midpoint from the chin to the vertex, 13, 14 centimeters. But the head is heavier down this end where the brain is, so it's not quite halfway along. But it is 6 or 7 centimeters from the vertex, and if you put the cup there, it goes out another centimeter or two. So, and the point I'm trying to make here is that while we can manipulate the head here, it's swiveling and pivoting back here at the level, at the widest diameter level, about 6 or 7 centimeters behind the cup. So, as far as the technique that you then have to apply is, you work from here, but you're thinking back here. So that until that midpoint of the head comes out from under the pubic arch, and that's a long way. You see the cup for a long time before, well, sure, it comes up because the canal is curving, comes up a bit, but you shouldn't be pulling significantly upwards until you reach the midpoint, the pivoting point of the head. So, and what's happening? Some of you taller guys, your back's starting to get sore when you're working down here, and you see the cup and you say, oh good, I'm pulling upwards. Where do cups come off? They always come off when you can see it. Why? Well, that's one of the reasons, if you're pulling upwards and the head doesn't want to pivot upwards. But the other reason is that the widest diameters of the head are back here, and they're just entering into the funneling of the pelvic floor, which is the narrowest part of the birth canal, not where the spines are, that's the narrowest bony point, but the most resistant part is from, at the level of the pelvic floor, particularly when it starts funneling down to the introitus. So, from your technical point of view, you're working from the flexion point and you're thinking at the midpoint of the head, and it's easier to do that on here. Next, thanks, Landon. So, I mentioned 5 steps, and these are they of every vacuum delivery. And we've talked about the first one, probably the most important, because if you don't get this right, the whole cascade effect will mean that the outcome may be less than you'd like. You locate the flexion point, and you'll be doing that. You calculate the cup insertion distance, the center of the cup, by the way, and you go for that distance. Your brain will cut in long before you reach it in many cases and say you're in too far. But if you've actually measured it, you just tell your brain to back off a little bit. I'm going that distance whether you like it or not. And that's, I know I'm being a bit sort of facetious here, but that's what's happening. We're not putting the cup in far enough. We'll come back to that. Holding and inserting the cup, well, if I passed, we're using this cup in this hospital? Now, we've got the manufacturers here. I've got to be careful what I say. But when I designed this cup, I didn't call it that. I call it the Omni Cup. But, Kiwi, that was a master stroke of commercial sort of thing. But anyway, because there are other Kiwi devices that I had nothing to do with and, you know, are useful in certain circumstances. But this is an omni cup. This is a cup for all occasions. So here I am trying to say, I'm simplifying things if I can, but I'm not trivializing things. You've got one cup for all occasions. You've got one technique for all occasions. If you can just understand how you can put the two together, then, you know, we may be making some progress. The step 3, then holding the cup. Yeah, I was about to say, if I pass this around, a lot of people will hold it like that. You know, there's not that much room in the introitus to actually insert hands or fingers and cup. Why not just hold it so that the cup is the largest object that you're doing with, this is the way I would suggest. You know, there are always more than one ways of doing things, but I've tried them all. And I'm going to suggest, so you can humour me today and then do what you like when I leave. But if you put your thumb on the tube in the grooves, the way I put it, with a couple of fingers on the rim, it means that your hand, or you've got good control when your hand or your fingers are behind the widest diameter of the cup, so that you've still got control when you get it into the introitus, because you do have to manipulate and then manoeuvre the cup. That's step number 2. And I made that a separate step because I see people fumbling around. I mean, all of you can or will be able to very soon, you know, stick a loop over this small ectopic pregnancy and not even look at the patient, look at the screen and do all these I can't do that. But the residents back home come to do a vacuum and they're all clumsiness and everything. So this is, I'm trying to reverse the trend, you know, and say maybe we should get these rather simple techniques right and then worry about the high-tech stuff later on. Then the third step is, once you've got the cup in the introitus, manoeuvring the cup. And that's done with 2 fingers. You only have 2 fingers in the vagina at any one time. 2 fingers to find the flexion point, 2 fingers to retract the perineum, and you'll see this in a moment, and 2 fingers to manipulate the cup. They're different fingers, but 2 fingers, and then 2 fingers during traction. So manoeuvring the cup toward and over the flexion point. I'll describe this briefly in a moment, but it's much easier to do on here. But as I said, it's all happening out of sight, so you need to have a fair idea of what we're saying, unless you're already doing it, of course. Creating the vacuum and excluding maternal tissue is important, because there are still reputable textbooks in your country and mine that are saying lower the vacuum slowly. Well, evidence from this country, interestingly, most of the evidence I use has come out of the United States, but long before you were born, you see, so you wouldn't know about them. But I do. And yet, we're doing things like reducing the suction slowly, reducing the suction between contractions, maintaining station. All of these things have been shown to be of no value whatsoever, or not useful. So why do something when it's only adding more steps to the whole thing? So you create your vacuum quickly. Method of traction, again, we'll describe it, but next slide, thanks. I'm going to, we'll talk about that as we come to it. Step 1 is what I was saying before, and there's a few things maybe just so that you don't get too confused here. Method of traction, determining fetal position as you do. Put your finger on this is the traditional method, on the posterior fontanelle, and over here, you know the flexion point is 3 centimetres in front of the posterior fontanelle, so drag your finger back. The hand doesn't come out 3 centimetres because you're going through a curved fetal head, so you're only coming out 1 or 2 centimetres. And as I said, when we're working, this one you'll actually feel a rough and groove. The whole point of making it there is so that you get used to doing this, and then if we had more time, we'd go to this head, which has got a scalp, so you've just got to say, well, that's where the flexion point is, more realistic. Now, okay, well, you can put your finger on it. How do you know it's in there somewhere? I mean, I can show you this. Well, it's being rubbed off, but there's the flexion point. But when I put it inside here, it's disappeared. I can put my finger on it. Well, the good thing is, if I told you that each of you in this room has a finger length from your knuckle to your tip of 10 to 11 centimetres, and if you all did that to me, I'd say 10, 11, 12, so I'd know exactly what your finger length was. The middle finger is your longest finger, and 5 to 6 from your proximal interphalangeal joint. So we've got a biological ruler on the back of our finger, I think the good Lord put there so we could do a vacuum more accurately. But we don't, you know, we've disregarded that. So you think they're just there for joint movement. No, it's not. Well, the point is, if I do that and then supinate my hand and lower it there, I need a bit of lubricant, but I can sort of tell that's about 8 centimetres from the perineum, and that's 8 centimetres, and you can do that, you know, without looking. So if my finger is 10.5 centimetres minus an inch, you're at about 8 centimetres. So you can measure it. That's all very well, but when you just pick up a cup, those of you who use this cup, has anybody ever noticed these marks on here? Ever noticed the marks? You half nodded your head. Nobody else is game. Come on. We'll give you the day off tomorrow if you can sort of. I don't know how well you can see them, but that's 6 centimetres from the centre of the cup and 11 centimetres from the centre of the cup. And to me, that's the best idea I've had in obstetrics, but few people know about it. Why is that? Because if you can measure the distance to the flexion point, and then you can extrapolate on here. I measured 8 centimetres. This one you might be able to see better. There's 6 centimetres, or it's better to work backwards because this is inside. 11 minus 3 is 8. So when that part of the tube is on the perineum, you know that the centre of the cup is in the same plane as the flexion point. The other thing I want you to now come with me here, because this is where you really need to pay attention. Oh, here's the head. You know, I'm trying, it rubs off very easily. I must ask the manufacturers to get some paint that will stick on silicone. We had one, remember we had one which was very good. It saved me doing this. This is where I want you to come with me here now. In this particular lady, the baby was left occipito-posterior. These diagrams are right occipito-posterior. But I would do the same technique for both of these. Again, we've been programmed into saying left occipito-posterior or anterior, whatever, and right. Well, if I told you that it makes no difference in technique because you don't have to go one side or the other at all. You go midline for this reason. We've been programmed. Let's take left occipito-posterior. Can you see that mark there, and perhaps and that one? Let's go left occipito-posterior with asynclitism and deflection. Remember, you're working from up here is where the introitus is. You're looking down to the parietal bone. What I'm saying is you need to know the distance from the perineum to the flexion point. But we go over here, and then we come back 3 centimetres. You can see that in a left occipito-posterior, the flexion point comes back towards the midline, irrespective of asynclitism or deflection. Sure, it moves a little bit, but if we then rotate it to the right occipito-posterior, give a little bit of asynclitism, a little bit of deflection if you like, the flexion point has just moved from here to here. It does move through a, you know, an arc or a circle, but much smaller than the posterior fontanelle that's gone from here to here. So this stays nearest the midline. Not far, but certainly near the midline. It may move a little. And besides, you know, when you have an oblique posterior or a transverse in particular, there's no room for the head to deflex and flex too much. I mean, with a posterior it can deflex, but here you've got spines. The head nearly always flexed in the transverse position. What changes is the asynclitism, and you can see the flexion point goes back further depending on the degree of asynclitism. So when you measure it, it really doesn't matter because you measure it back here. If you take a transverse, as I started to say, right occipito transverse with a lot of asynclitism, and you know we're afraid of those words, deflection and asynclitism. Whereas if the residents back home call me and say, "Oh, we've got a head and there's usually a lot of deflection, and whatever that means, and a lot of asynclitism," I say, "Good, because we can correct that." I'm happier with a deflexed asynclitic head than I am with an anterior head. If I can't see it. In other words, I don't mean when it's right on the perineum, which should be anterior. But heads are not designed to be in an anterior position up the pelvis a bit. You know, I begin to wonder, is the pelvis a bit odd? Because they're more inclined to be transverse, or certainly oblique anterior, or posterior. So, you know, we've got to realign our thinking a little bit here. But what we're doing now is I'm trying to suggest and hopefully convince you that the flexion point is always near the midline. If it's transverse, it's in the midline. If it's oblique anterior, it goes down towards the midline, irrespective of position. So if you get this distance right, you don't have to worry about moving. I rarely move a cup to one side or the other, unless my fingers, because as you'll see on the models, when you're feeling position, your fingers may go to one side, but as you come back, have a look and see where your middle finger will be lining straight up and down the birth canal. So if you measure that, now I measured 8 centimetres, and I've had people say, we don't do vacuums that high. Well, I can tell you, you do, because we're not talking about station, which is taken from the most dependent part of the head to the spines, which are back here. We're talking about something completely different when we're talking about distance to flexion point, and that is the distance from the flexion point to the perineum. Now, that's going to vary with station, obviously, with position, obviously, because if it's an anterior position, as the head comes lower, the flexion point is the most dependent part of the head, so it'll be closer to the perineum, but as it rotates around with a bit of asynclitism, it tends to move it away, and particularly transverse, it moves it away, and if it's posterior, the deflection moves it away, but always close enough to the midline. Now, that may have confused some of you, but it'll be easier when we do that. Step number 1, by the way. Step number 2 is holding and inserting the cup, and you can see that I've got my thumb on the cup, and I tend to roll it in. We'll be using a lot of lubricant on these because, you know, rubber on rubber will not slide, but I rarely lubricate the cup at all. And if a well-meaning midwife at home puts some gel on the or cream on the trolley, I will just pick up the cup and dip my finger in it and do that, because I don't want to hurt anyone's feelings. But there's enough lubricant there, if you know what you're doing, enough lubricant there to do it without upsetting the mother. So I'm holding. See, remember I said there are 2 fingers to find the insertion distance, point position, flexion point, insertion distance. 2 fingers retracting the perineum. The reason I said, and I roll it in, so I'll try to come over here. I roll it in, retract my perineum here, try to get where you can see it, roll it in, and then let go. Now, if you think it's kinder for the woman to hold the cup sideways, then hold on to it back there, because that's why I say you need to be able to have control of the cup after you get it in the introiters. So if you get it in the introiters and then hold on to it, look what's happening. What I'm trying to say is I want the groove that you see there to end up against the baby's head, irrespective of position of the head, anterior, transverse, or posterior, at 12 o'clock to the mother's, in other words, under the symphysis pubis, 12 o'clock to the mother's birth canal, because it's a very good use, a marker of rotation. Don't line it up to the sagittal suture, as some books suggest. So if it happens to be right occipito posterior, as shown there, with the occiput here, as the head rotates around, the groove will rotate in the opposite direction. If it's oblique anterior, left occipito anterior with the occiput over here, as the occiput straightens up, you'll see, well, if you put it, sorry, the occiput's over here, you'll see, if it's LOA, when the groove is ROA, then you know the occiput's anterior. It's not absolutely essential, but it's a very good practice point. So what I'm getting at is I just roll it in, and it'll fall like that usually, and most times. But if you're holding it like so, inserting it like so, hold on to that until you rotate. Look at the elbow, go up, 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 up. And then when your thumb, if you like, is at 12 o'clock, because your thumb is on the groove, when your thumb is at 12 o'clock, it'll automatically fall there. If you're not sure what I'm trying to say, hold that thought and we'll do it on the model. But it's you know, no hands here, just fingers. And I think if you want to be gentle and so on, then I'd follow these sort of thing. Next slide. Step number 2. Step number 3 is maneuvering the cup. So what I've said, I get the cup this way and I'm working front on, and then I would suggest, there should be 2 left-handers in the room. How many are there? Well, you're not a normal group, you're a highly intelligent group. So we're all right-handers, that's good. You're working front on, and then you do this. these two fingers for manoeuvring the cup. Don't worry too much about doing it at the moment, but you turn this way and you've got two fingers in there, mirror images, your hands, elbow facing the mother, this elbow in the same plane. This finger, if your right hand, pushes the cup. When I say put this finger on the top of the rim of the cup, so in other words, you've got your one finger here on the baby's head. That diagram is halfway through the procedure, but you've got your pushing finger, as you can see, on the top of the rim of the cup, because don't put it here, as a lot of people seem to, you'll go nowhere, you'll just push it up against the head. You've got to get down and around much as you do with the forceps going around the cephalic curve. This finger initially, if there's caput there, will compress the caput to make a bit of room for the leading edge to get in, but thereafter all it's doing is following. Your fingertips are always very close together and you don't need much force, but you get more than enough force in there. So you're pushing, follow, push, follow, push, follow, push, follow, until the mark on the tube that you estimated should be on the perineum is on the perineum. And that's where this finger, your non-pushing, comes into view. If you just took both hands out, the cup would tend to slide back out to the initial position. So you've always got to have one tip of finger against the cup. So initially to maneuver the cup to the right position, and secondly, because your fingers are together, when you want to take this hand out, your dominant hand to pump, you just slide that finger up against the cup to stop it sliding out. Now, that's what you'll be doing in a moment here. So, and you can see, I measured in this woman, she had a posterior position, the baby anyway, there's the 11 centimetre mark, you might just be able to see it. The perineum's up here in the shadows, and there's 9 centimetres. 11 minus 2 is 9. So when this part of the tube is on the perineum, then I know that the centre of the cup is on the flexion point, or very near the flexion point, bearing in mind that the flexion point is near the mother's midline. So it is, you don't, with practice, again, you don't have to try to check that the cup is in the right position. If you get this right, it will be in the right position, or very close to it. That certainly doesn't matter too much. If I took both those hands out, the cup would tend to slide back out again. Next slide. You can see then I've just transferred fingers so that I can create the suction. This is step number 4, and simple as that. Next slide. We'll go back one. I just want to point out that here you may be able to just see the 11 centimetre mark 2 centimetres from there. So I'm actually, holding the cup in, looking here to see that I'm in the right distance, and then pumping as rapidly as I comfortably can. In this situation, to get to, well, even the next stage, next slide, to this stage where I've checking for maternal tissue, and I'm ready to go. That only takes half a minute, less than half a minute. So, it takes longer for me to describe it to you than it does to do by a long shot. I also want you to, what you should do is, here I'm waiting for a contraction, I'm talking and saying, and you'll see the video of this in a moment, which will bring all the steps together, saying I know I'm in the right spot. You don't have to go fiddling in and saying, am I in the right spot or not? The other thing I want to say is, I've said here this is checking for vaginal tissue entrapment. That's what I'm doing here. Remember I said you're working side on like this after a while, when you're manoeuvring the cup. You get to you're holding the cup in, you're creating a vacuum, and before taking this hand out, you just run your finger around the perimeter of the cup that is nearest you, because there's no way in the world that anybody in this room would have been able to get to the most distal part of the cup. And anybody that says, oh, I went right around, and this is one of the things that you and I are expected, or by the recommendations from our college guidelines, expected to do, well, I can't do the impossible, and I dare say most of you can't. However, I don't believe you can trap maternal tissue at the level that you can't reach in this situation, because you've got a head 10 centimetres at least pushing the vagina out. You're squeezing a cup which has a depth of, 1.3 centimetres. You're squeezing it between the vagina and the baby's head. Sometimes it's not that easy. We're pushing the vagina out further, and then we say we can suck vagina back. Well, that's hard to do. I'm not saying for 1 minute that you shouldn't test, because here I am doing it. But I'm saying I've seen people try so hard because the recommendations say we should do it, that they indent the scalp, a bit of air gets in, and the cup will come off, which doesn't seem right to do that. Where you do have to check is in the low anterior position. If you think I've got to worry about an anterior position, you're quite right. And if you think I've got to worry about an anterior position that's low, virtually on the perineum, you're quite right. Because lots of reasons. Because that's the only time the bulk of the caput is over the flexion point, and it may reduce the adhesive efficiency or effectiveness of a cup. It may. But that's one thing. But the other thing is that the vagina does come around in front of a low anterior. The vagina is heading for the introitus and the perineal body, and the labia may fall around in front, and you're putting the cup directly. That's the time you really need to exclude maternal tissue, or try, and fortunately we usually can. So where we can't, I don't think it's that important. Where we should, we usually can. So anyway, you can come back at me on that if you think I'm preaching heresy or not. So this is still step number 4. It all happens quite quickly. Next is traction. Now, we overdo traction. You get more than enough traction by just flexing your fingers. Tuck your elbow into your side and flex your fingers. And I've tried to show that there, that, just do that. I can't pull any harder, and that's just fingertip traction. I just cannot pull any harder. So don't grab it and grit your teeth and grab it with the other hand. You don't need to do that, because the most important hand, and you can see I'm using my fingertips, and the other thing that you see here is axis traction, which is downwards towards the floor initially, to flex a deflexed head or to correct an asynclitic head. So there are some books that say, well, let's pull upwards, but you now know that if you pull upwards here, because the midpoint is well above the pubic arch, you're going to detach the cup. The head doesn't want to go upwards in that direction. Now, if you had forceps on that with the shanks, it'd force you to pull in roughly the correct direction. But because we can do it, we pull upwards here with a vacuum. Well, don't. But anyway, by far the most important hand is your non-pulling hand. It's this hand. And I maintain this position until the head has delivered. And the other thing I'd like to say is I rarely pull above the horizontal, because by then the natural forces in the head hopefully will be coming towards the anterior position and starting to be borne by extension. The midpoint is coming out from under the pubic arch, and the natural forces will take it up. If you want to go upwards, that's the time to go upwards, but go with the natural process. Don't force the head upwards. In other words, we all pull upwards too soon. Now, what is this thumb doing? Well, this is the most important hand in traction, and this is the most important part of your most important hand, because it's really controlling descent. It's monitoring descent as well, but controlling it, and it's controlling the amount of force that you generate here. By pushing back, you will reduce the force that you're generating here. You'll reduce the force that's on the baby's head, or the force that will detach the cup, or the force that will cause progress. So you need to have, you're not pushing back actively, but you're doing a lot of intuitive things, which you'll do on here, as you'll see. Your thumb also, as the head comes down on the perineum, so that you can see the cup, the thumb will help. It's the best tool you've got to help reduce, if not prevent, detachments, and you can do that with technique. So, next slide. There are a few things here I just want to say about traction. We've talked about axis traction, because look, here, if you're delivering the cup, you would be wanting to keep the cup in the axis of the pelvis. Well, but it's the midpoint of the head, and that where roughly where the mentovertical diameter is heading. It doesn't want to go along the axis of the pelvis, not the cup anyway. The midpoint wants to go, well, it wants to go along the axis of the pelvis, sure. So your direction of traction has to be more posterior for a lot longer than you think. And you know, as the head comes down, and if there's a rotational element, it rotates. But you're thinking back here while you're working here with your thumb on the cup, and you're kneeling down, pulling in that direction. Now, here you're saying, well, how are we going to pull in that direction through the pelvic floor? Well, we don't have to, I can tell you. But look, it's a long time before the two virtually coincide, where you want your direction of traction more or less to coincide with the axis of the pelvis. You can see the cup at this stage, and that's part of the problem. I'm saying that you're working from here, you say, oh, I'm going to deliver the cup, pull upwards, but the head, well, at this stage it probably would go with you, but, you know, until this is out from under the pubic arch, it doesn't necessarily want to go. That's not the optimal direction. We usually get away with it, thank goodness, but when it goes wrong, it can go horribly wrong. And I rarely pull in that direction. You know, by the time you get to this direction, as I say, the natural forces are extending the head. Next slide. I just want to share this with you. I don't know if I showed this when I was here last. I think it might have been before 2000. Well, I published it in 2006. Now, I looked at 119 nulliparous women, and we measured the traction on it. And, you know, this is nulliparous. You've got to look at nullipary if you want to see how good or bad you are with a vacuum. And look, we've got this biphasic pattern in 3/4 of them. The others had a more even pattern, but none had a lower traction force at this end than this end. But so, you know, and how did I define descent phase? And this is a point that I should have brought out. The descent phase is when the cup is virtually visible in the introitus. Because if you're thinking 7 centimetres back where the widest diameters are, it's just those diameters are then entering the narrowest part of the birth canal, which is the pelvic floor and perineum. And so you can see the same thing. There's an incremental increase in resistance. This is measuring the traction force to overcome that resistance. And you know, it sort of fits in with what's happening while you're doing it. But we've got to realize that the lower down the head is, the more resistant is going to be the requirements that you're going to have to meet. So your traction force will go with that. So imagine, and cups always detach here. It is unusual in my experience for cups to detach here. So, you know, again, this is the risky part for the baby. If cups are detaching or there's no progress here, you better stop and do a C-section. Don't even think about using another method of delivery. But if the cups detach here, please don't blame the cup. You know, there's increased resistance. One of the practices that has changed in my lifetime is that we've become selective in episiotomies, just as we've done with normal births, and I go along with that, but I would then allow, as I said, more pushes at this stage, your work, and just apply additional traction just so that you've got progress, to give time for the perineum to stretch, particularly if you're not going to do an episiotomy. Here's a mother we threatened if she didn't do something, we'd go and do an episiotomy, and she's certainly trying hard. The peaks you see here, when you put your thumb on, you push back, it registers as a peak. But again, look at the average. You know, in a multipary you get a lower peak force, if you like, but it's a more even graph. Next slide. Remember that. So and this is how I define descent and pelvic floor phase. But remember that if you say, "Oh, I only do low vacuums," well, good on you. You haven't avoided, as I said, the most resistant phase. The descent phase is from when you start and you can't see head or cup up here. She was left LOP with a lot of deflection, as I said. And this is what I'm doing with my thumb, which you can hardly see, and the index finger goes over the caput onto the scalp, where you can feel cranium under the scalp. It's sort of, that index finger is important. It monitors descent. What else is it doing? Well, this is something that happens rather subtly, but we'll try to get you to do it today. So, well, by the way, you notice this is color-coded. I say go to the top of the green, which is 600 millimeters of mercury. The range is the green, but I would say eliminate the green, because if you're pulling and you start seeing green, it means you're losing suction. So that's another if you like, a warning sign of imminent detachment. So if you see that, stop pulling and go back just up to the top of the green, but so you can't see it, or can't see it significantly. So what's happening with your finger here? Your thumb is there, always on the sort of the end. It starts there, and if there's rotation, keep it on that end towards the midline, because if you're pulling downwards, it's this edge that's going to come off. But this finger, if there's caput there, move it till you can feel cranium. But it also slides back, and as the head comes down, it slides back. It doesn't keep going, but it slides back. So when this finger is, the tip of this finger is out from under the pubic arch, apart from monitoring descent, it's also telling you that the midpoint, the widest diameters of the head are coming out from under the pubic arch. So, you can then start coming up. You can see this was initially, and as the head comes down to almost, I still think that's the end of the descent phase rather than the beginning of the pelvic floor phase, but you can imagine we're working from here. We've got an awful lot of space up here, but why not pull upwards? Well, you know why not, because the head doesn't want to go upwards at that stage. If you're thinking, that's still a centimetre to the perineum, another centimetre or more to the head, and the midpoint is still another 6 or 7 centimetres up there somewhere, then it doesn't want to go in that direction. It still wants to go downwards. People are saying, well, pull at right angles to the cup. So apart from when you're correcting the attitude of the head, or the malattitude of the head, the deflection and the asynclitism, you can usually get this direction pretty well at perpendicular to the cup. That's a guide, but each head, depending on the amount of caput, and the baby had a lot of caput between my thumb and finger, and caput does impede rotation and to some extent descent. So, you've got to adapt your technique to some extent, but in general, you pull further down for a lot longer. Next slide. Thank you. Episiotomy, I don't want to say any more. I do it if it's necessary, but if I don't do it, I will give more time for the perineum to stretch. And I think that's another reason for dividing it into a descent and a pelvic floor phase, because, the so-called 3 pulls rule is certainly something that's been misinterpreted, isn't it? A woman called Lasbury in South Africa in 1964 coined the phrase, the 3 pulls rule. When I looked at her paper, the average number of pulls was 5, which would be your average numbers, and which is my average number of pulls. And I said, well, people are interpreting your pulls as the baby should be delivered in 3 pulls. Well, only 27% of those nullipari I showed you one graph of, that were delivered in 3 pulls, 27%. So again, we're being, guidelines or recommendations are being imposed on us that we can't achieve in the majority of cases. The only way we could have was to pull harder, and then you would have had all the risks of detachments and so on. Anyway, she said, no, if you don't have significant, well, you should have progress with each pull. That goes without saying. You should have an expectation of progress with each pull. But if you don't have significant progress in 3 pulls, that's the time to stop. So it's not that you must deliver in 3 pulls, which is, making it not only difficult for us to achieve, but I don't think it's necessarily good for baby. Particularly if you're not going to do an episiotomy, you really need to give time for the perineum to stretch. It is rare that we're saving this baby's life. If you're concerned about the baby, sure, do an episiotomy and pull a bit harder and get the baby out. But most times we're not in that much of a hurry, so we should back off a little bit at this stage and get the mother pushing. As long as there's progress, you add a little bit of pull. What type of episiotomy you do is up to you. But I've always done medial laterals, and now your college is suggesting that for instrumental deliveries we should be doing medial laterals. I don't want to go down that track. We could sit here and talk about that all day. Next slide. The other thing, and we'll finish on this, is auto-rotation of the head. And it is important to realize that I have never rotated a head in my life with a vacuum, but I would expect to get 90% rotation from a posterior and a transverse position. I would expect the residents at home do that as well. And I would expect that you would reach, and I'm being generous there. Anyway, that's another story. But what I want to show here is that if you put the groove at 12 o'clock and you can see it's now at 10 o'clock, that's suggesting there's some rotation. Now, rotation occurs at all levels. In a multipra, sometimes you correct the deflection and it'll spin around 180 degrees at that level. You rarely see that in a nullipra because it tends to start rotating, and a lot of the rotation will occur, as you'll see in the video in a minute, when the caput comes out from under the pubic arch. It's well known that caput will stop complete rotation. And in this case, because of the caput, I'm still pulling, well, I'm not pulling, I'm just guiding that head so that it is staying down to allow the caput, which is between the fingers, to come out. But you are looking at the at the groove moving. It was LOP, so as the occiput rotated this way, I would have expected the groove to rotate to the ROP. Next slide. And I just want to point out, this is 25 years of my obstetric life, starting in New Guinea in 1976 and finishing here in the United States in 2001, just after September 11. So it was, I lived in with the residents here, with, you know, and I have to say it was instructive, because when I first started coming over here, people, and at ACOG, they used to say, don't ever try to rotate with a vacuum. Well, you know, I grew up with the Bird's posterior cup, which you must use, and I've incorporated that in the Omni cup, and it wasn't such a strange phenomenon. But everywhere I went, people, not just here but elsewhere, would say never try to rotate. Well, here's the green of the rotation rates from all posterior and transverse positions. There's about 1,000 deliveries here, where the cup was placed over the flexion point, and here is where it's, over or near the flexion point, and here where it's not. So you can see you'll get a 90% rotation here. This was in New Guinea, and the midwife did half of these. So, you know, it's not a highly technical thing. The only technical thing is put it in the right spot and pull in the right direction. But it's not to say that you won't get some rotation, but the rates are so different when you get it right or wrong. Here are two hospitals in England. Well, no, one hospital, but two series in England when I was there. And here are two hospitals in where I'm sort of in the region I'm working now. And when I came over, as I said, I lived in, and we haven't done many, only 8, but 7 of the 8 rotated. And I didn't do them, the residents did them. So even American babies and American residents will achieve rotation, so there's not that much difference. It's an attitude and an ineptitude, if you like, in terms of not doing the essentials. I dare say the one that didn't rotate was in the second stage for 7 hours, pushing for 4 hours, because everything natural is good, naturally. The head, it was a deep transverse arrest, and of course people said never use a vacuum in a deep transverse arrest. If you asked me where I would prefer to use a vacuum, I would say in a deep transverse arrest. Because it's an attitudinal thing, not only the operator but the baby. The attitude there is deflection, asynclitism. You correct the asynclitism. If you don't do the sort of things we've been doing and making an effort to get that cup right around to the flexion and put it on the parietal bone, which is what's happening, of course you're not going to achieve any success or not even delivery. Of course you're going to pull the cup off. Heads were not designed to come out, I should say, in that position. But in this particular lady, the resident, after, and I'm stressing it, 4 hours of pushing and 7 hours in the second stage, put the cup there, corrected the problem, and it came out in one pull, or well, in one push, one contraction. So I was a bit surprised too, but it certainly made a statement regarding correcting the problem rather than just overcoming. And the head, the reason it didn't rotate, it was in the second stage, if you like, so long. There is actually banana shaped along the axis of the pelvis, you know, sideways. But once the asynclitism was corrected, so I put it to you that if you do that and don't rush and do the right thing, that you'll get rotation in most cases. Next slide, I think, yeah. And I guess this is now, if you like, the bridging slide. Everything that you see after I show you a brief video, and we'll have a bit of a break or question time, whatever you like, we can actually replicate on here, including rotation delivery, with a little help from me, but not a rotational help, just by increasing or giving you some retro resistance. So we haven't quite created woman, but we're getting awfully close. Now, if you minimise that, thanks, Landon. And Natalie, are you here? You're the... Yeah, oh, okay, the second one there. That's right. Oh, God, Landon, you're pretty good. Open that up. Now, nulliparous woman in the second stage with epidural, pushing for 1.5 hours, left occipital posterior position. Step number 1. Here I'm checking for position. When she agreed to be filmed, I got excited and forgot to put a drape under there, but don't worry. My knuckle, maybe if we can turn the lights off, my knuckle, see, I'm now on the flexion point. You notice I went into the posterior fontanelle, thank you, and came back. That's 9 centimetres. And that's low. This is not mid, this is low. Step number 2, retract perineum, insert the cup like so. Right. Step number 3, lifting, compressing caput, pushing this end. You'll see the pump end of the cup rise. Step number 4, I'm holding it in with that finger. I'm making sure that the marks, you can't see the perineum so well. That's still checking for maternal tissue. Don't try to go back. Now I'm waiting and I'm saying the groove, the mark is 2 centimetres out of the outside. Here's step number 5. Down on one knee and pull towards the floor. Look at the length of the tube lengthening. So that's all just flexing of the head. And you see that first by the tube lengthening. Fingertip traction. My thumb isn't touching the cup there. This thumb. The other thumb is on the baby's, on the cup. And you can just start, the cup is the white thing that'll come into view about now, I think. My index finger is over the caput, and I'm saying I can see rotation happening because the groove is moving that way. You keep your, as long as you're pulling, you keep your thumb on there, and certainly if you want to control the descent and so on, your thumb is by far the most important part of your anatomy. Now, this is as high as I get, I think, because I'm experimenting there. I'm saying, well, it came down nicely. Is the caput complicating the descent? So I've actually, now we're talking in between contractions. I've never reduced the suction. Now I've got evidence, see the groove coming around, evidence for not doing it. I don't maintain station. Let the head retract if it wants to. It'll always come down to the lowermost point reached in the first millisecond of the next contraction. So I'm just holding the cup there. Here's the second pull. Down on one knee. You see the direction of, well, I do go down. The direction of traction is still below the horizontal, not as vertically. This is now 1.5 pushes to get to the start of the pelvic floor phase, because I'd normally keep my thumb there. I'm trying to let you see the groove, and there's hardly any traction there, but now I could have got away with that in a episiotomy here, I'm pretty sure. You never know both sides of the story. But I also always have a feel around, because we're getting good at protecting perineums, but the forces are distributed, you know, up besides the urethra, paraurethral tears. Now that's probably now in the, certainly heading to, so I always do that as the contraction goes, and while the head's still, she started to tear, so we did an episiotomy. But look at the groove, it's gradually coming around. Now I want you to focus on the groove. There's hardly any pulling there. The mother's doing most of the work. My thumb actually starts pushing back. You've got to have some progress for the completion of rotation. I'm keeping that caput up here, out from under the pubic arch. And look at the groove. It'll come around. My thumb, you'll see, will start actually pushing back to control the descent, like here. There's no traction there at all, so I'm not. And look at the groove come around to ROP position, which means that the occiput will then be under the pubic arch. Now, this is your standard. I wish they were all do what, you know, I wish they all did what you wanted to do when you're demonstrating. But look at the caput. You can't see it very well. There's about a 4 centimetre caput. That's the presenting part. And if you just put the cup in the introitus and don't go chasing the flexion point, you'll end up here. And of course, the diameter at right angles to it is always going to be greater than the diameter at right angles to the cup over the flexion point. So, I mean, we'll have a bit of a break, and those of you who want to ask me questions, but then this is where you roll up your sleeves and put some gloves on, and maybe we can do a demonstration. Any questions on that? Confused you totally?
How long, I do have a question. How long did you allow the cup to remain under tension?
20 minutes. Those 190 nullipary, all multiples are delivered in 10 minutes.
If you know what you're doing. If not, you've really got a problem on your hands, in my opinion. Time is one dimension. You've got to relate it to strength and frequency of contractions and mother's propulsive powers, So when you just pluck one sort of, what's the word, the air, you've then got the sort of a little bit realistic, but you're right, 10 minutes. 85% we record, all of them, 85% of nulliparous women are delivered in 15 minutes. So where's the clock that's being hidden there, but nevertheless, it's about, is that 1:15 already? Yeah. So I will say, listen, if you get your act together, you'll have your baby in 15 minutes. So that's, you're stretching the point a bit. But all of those 119 nulliparous women, bar 2, were delivered in 20 minutes, and that's pretty standard. I grew up with, 10, 15, 20 minutes without rushing, and that's not saying I've got to with this baby in a certain amount of time. You don't do any harm by keeping the suction. It's not what causes the problem. It's what you do after you. I knocked that off. Thank you. It's what you do afterwards, where you've got the cup on the baby's head and how hard you're pulling it in what direction, etc., etc. 20 minutes, and all those 2 that weren't delivered in 20 minutes, I did, because the woman was contracting 7-minutely. So you're only thinking, and that's a problem in its own right. We leave our women now for hours in the second stage because, as I said, it's normal and good. Don't let those doctors intervene and so on. But you're paying a price for it, and particularly we can keep our women comfortable. In my day, we did it in almost about 90,000 deliveries in New Guinea in the 8 years that I was there without an epidural. Now I don't know how I could practice without an epidural, doing this thing. So you can. We were doing episiotomies fairly, regularly with an instrumental delivery, and we wouldn't leave our mothers push. And even in New Guinea today, you're not dealing with the sort of healthy population you're dealing with here, but even today, you wouldn't just allow them exhaust themselves. Many of them were anemic and malarial and big spleens down to here and so on. But so even in your environment, I think 20 minutes you'll deliver all your babies if you know what you're doing. What about number of pop-offs? We could go on, and I some of you then, if you're not too tired or bored with listening to me, I want you to come up. Here we are. I'll pass them around. You've got mediums and large gloves. How many of you are hoping to do all this? When I do a workshop at home, I do 3 hours and limit the number to 10. There's a pre-test and a post-test. So, again, maybe it's not just the colleges that ask us to do the impossible. So these are large, and these are mediums. You open that one.
I have another suggestion, and you probably discussed this, but I'm trying to sort out how the distance to the perineum determines that it's on the flexion point. Doesn't that have more to do with station?
You shouldn't have asked that question because you're going to be the first one to demonstrate it to everybody. Do that. Look, it's easy, as I said, it's easier to do it, and that's where these three-dimensional models have made a huge difference. I had all this sort of problem trying to describe in a two-dimensional world. You're sitting down looking up, and usually the screen's a lot higher than that, whereas you should be up on the ceiling looking down, if you know what I mean, because here we are working, even with the bed up, we're working downwards. And it does alter it. But coming back to your specific question, you'll be doing it. So if you don't believe it when you see it, I can't do much more than that. Come on up here. Don't be afraid. I won't bite you. Not all. No, I mean all of. So look. Put some gloves on there, Landon. I'll just do a quick demonstration. All of you get your gloves. Don't put them on until you're about ready to do it. It gets very hot, Nobody gives me air-conditioned gloves, Landon, But no, it'll be a lot easier. Then you can ask the question after we do it. Your name is Hillary.
An amount, if you can even quantify cabinet, that would make it not possible to do the bed?
That's a good question. The answer is caput. I think I might have mentioned caput is only a problem in an anterior position. And that's one of the things that makes me worried about it, because there's flexion point. it's the most dependent part of the baby's head, and caput will largely form over that. Whereas if you have a transverse position, say, with the more asynclitism, the better, because the more asynclitism, the further away from the flexion point does the caput move or forms. And if you have a posterior position, more deflection, the caput moves away from the flexion point. And if there's a little bit over the caput, I think that's a good thing, because it's a ready-made chignon. You've only got to realign it. What do you do when it's an anterior position? Well, you worry for a start, and you back off with your traction. Fortunately, in an anterior position, the head is usually lower down, and if you don't want to, if you control the urge to deliver rapidly and pull harder, as long as you've got progress, that's what I want to say, because there's no question that caput does impede the adhesion, but with the sort of mushroom type cup, the Malmstrom type cups, because there's a ridge in there as well as suction. I mean, soft cups tend to just suck onto the head, and caput will interfere with that more. Whereas with this, the widest diameter of the cup is greater than the diameter across the mouth, so you do get a bit of a ridge. Now that's a good thing. It'll give you more adhesive power, if you like. But if you pull that off, you're more likely to take a bit of the superficial layers of the scalp. So make sure you don't detach the cup, and that's where your thumb becomes extremely important. So, but to answer your question, well, in my hands there isn't. But if I find a lot of caput in an anterior position, then I back off with my traction. Now you might say, well, if there's, I'm more comfortable with forceps, and I'm got a lot of caput there, and the baby's distressed, or call it what you want, then maybe you go to the forceps there. But it is rare that if you know what you're doing, what I would tend to do is do an episiotomy, but do an episiotomy rather than try to deliver a baby with non-reassuring status and so on. I don't know if I've answered your question, but there isn't just a clear cut-off in any of these situations. But that's one of the reasons why I say the more rotated and the more deflexed head, the happier I am, and that's not a facetious. Oh, yeah, what are you doing there, eh? Come on, we've got work to do. We use, as I said, a lot of lubricant, so otherwise it just won't work. Excuse me. Landon's very good, but, I usually have my wife here because I can't afford anybody else doing it, but well, I'm glad she's not here because she tells me what to do. You know what women are like, but still. Now, come on, Landon, give me maximum deflex. So we'll put it in the left occipito-posterior position. Now, the good thing about this, we do have a train the trainers thing another time. Show me if you've done it right. Ooh, not bad. Now, so come up here. Come on, put your gloves on. You little teacher for asking questions. Any other questions? What we do here is you'd be surprised at the force. Look, have a feel. That's pretty low, isn't it? Low? You agree with that? Go and feel the posterior fontanelle. Show me your finger. You've got 10-centimetre fingers. Do you normally wear your rings into the labour and delivery room?
No.
Ah, good. Well, yeah. Don't you tear my perineum with that, I can tell you. When I see these big, sharp diamonds on people, I really... Just get where you can see this, because, I'm going to only say it once. I'll step over here then. Okay. Now, put your finger on the posterior fontanelle. Okay. What's the position? You want to hazard a guess? Hillary, what do you? Where do you fit into the cosmos of?
I'm an R3, third year.
Ooh, you're about to be let loose on the unsuspecting public next year, are you?
No, I have one more year.
That's what I said. Well,
yeah.
Okay, Nick, I meant another year.
Yeah. Okay.
Put your middle finger on the flexion point. On the posterior fontanelle.
Okay.
Drag it forward until you can actually feel it. Can you feel the little roughened thing along the sagittal suture there? Mm-hmm. Okay.
You're right.
Listen, she's intelligent. You don't have to point it out. Now, look, put your finger on the posterior fontanelle again. You'll have to believe me. See, it's going to your middle finger is going to the left. Mm-hmm. Come back towards the flexion point. Look at it come centralised. Mm-hmm. Right. Then, now hold it there. Normally, particularly in an Alipra, this is easier to do in real life. if you lower your hand like that, you'll actually feel it come up and hit you about there. But I want you to get one of your other fingers, start at your knuckle at right angles to your hand, and go up to the perineum. Don't go in the vagina, but up to the perineum. Come out and show the assembled mass. Oh, what are you doing?
So you want okay.
Don't lift your hand,
Okay.
but I want you to start at your knuckle, bang, go up to the perineum, and come out. See, if there's 10 centimetres, that's about 10 minus 2, so that's 8 centimetres. Now, this is a low station, is just there. We're behind station, and that's like the caput. Where are we? Like the caput, it goes, just as the flexion point goes behind or up further than the most dependent part, so too does the flexion point. And those of you who might have seen the finger went to the left to get the posterior fontanelle, and as we came back to the flexion point, it's central. Would you I didn't pay you to say that, did I?
No.
No, there you are. You can trust. We're doctors, you can trust us. Okay. So you measured 8 centimetres. That's step number 1, and all that takes is, let me put a bit more, because I like you, I'll put more lubricant. It works better. Okay, Hillary, come on. Pick up, follow me now. Pick up your cup. If you're not sure, hold it in your left hand and let it hang down like that. No, hold it near the end. Left hand. You know which is your left hand? Face that way. You hold it like that. Now put your thumb on the tube in the groove. You know, let it hang down. 2 fingers. Yeah, get a good grip so that this is the widest diameter, because this is what I want you to do. You know, you saw on the video, I just roll it in like that and out. In these steps, whereas in real life you do that and then go smoothly from one to the other. Those, just step aside so these ladies can see. Look where the cup has ended up. Vertical with a groove at 12 o'clock. Can you see that? Come on, I don't see many heads nodding. Right, so I want you to do that. I don't care how you do it. If you turn it, put it in sideways, then make sure you hold on to it until your thumb is at 12 o'clock. So, right. This is step number 2, by the way. Push it up with your thumb and take your hands out. Look at that. Did it end up at 12 o'clock? Pretty good, isn't it? Have a look. Perfect. Well, almost perfect.
Almost.
Right. Step number 3. Now, this is, sorry, I don't normally wear a mic into the labour and delivery, but still, I want the world to hear. Now, come over here. Not too far. Well, maybe sit there so they can look over your head. So, God, I've never had a woman do what I want like this. 2 fingers. Now, you're working like this. You turn that way. See how your hand falls? You go in between the top of the cup and the symphysis. Push it in there. There's not much room. There's a bit more room in real. Oh, by the way, you measured 8 centimetres. There's 6 centimetres. There's 8 here. So the cup is nowhere near the flexion point. We're about 5 centimetres, or 4 at least, away, well, 5 there, away from the flexion point. So you've got to go chasing the flexion point in the midline. So this is what you're going to do in a moment. This goes there. This goes, you know, it's a mirror image of your hand. This goes, there's not much room. You might have to bring that out so you can get to the top of the cup, push it down a bit, and then put your left index finger on baby's head and your right index finger there. Now, I can't see the marks, so don't try to look, because you see, if you want to look, you see how your finger will push the cup away from the midline. So I'm pushing down, follow, push, follow, push, follow. I want to have a look, slide my finger up against the cup and have a good look. Well, we're almost there. That's probably 7.5, but I'm just... So go back in again. Don't be afraid to go back and give another little shove. 11 minus 3 is 8, so that's where you should be, and I'll see if I'm... We won't worry too much about rotational things yet, because that's... So you pump it to the top of the green. Check for maternal tissue, because look where the cup is now. It's horizontal, and there's no way I can... And in 8 centimetres. That's not in too far. That's where the flexion point is. Unless if it's not there, I'll blame Landon for shifting the head. And look at the length of the tubes. That's step number. Let me just do this, and then you can do the same thing. Step number 5. That was step number 4, by the way. Step number 5 is this. I can see a bit of green there. I do that, but there's a groove in the suture does that. So get down on one knee, as I'm saying. Pick up your cup and your fingertips. Go in with your thumb, index finger on baby's head. Keep these 3 unwanted fingers out, because if you do that, you'll never get anywhere near it. Do that and pull downwards. Look at the tube lengthen. I felt the head flex. Look at the cup now. It's no longer as horizontal as it was, so it's halfway between. And that's really what happened in that thing. Remember I said keep an eye on the tube. This is 8 centimetres here, so something has happened. Not much descent. We've corrected the attitude. Anyway, we'll do it in one. Don't even try to. See, you're not rotating that, I hope. But it's starting to rotate even here as the head hits the pelvic floor, but I'm not giving it a chance. Now, this is the time that cups are detaching. There's a tendency to want to support the perineum. We only have 2 hands, and we need them both here. If you want someone to do, and I think, what do you call it? You do good for the mother's perineum by controlling descent and letting things stretch. These ladies are much more compliant than the real women. Now, if you want someone to do that, get an assistant. That's better. Good. And then at this stage, even here, you can let go now if you like. Even here, now the groove started to rotate. I didn't really give it a chance, but we'll do that more. And hopefully we're going to be over the flexion point. So, that was very clever, but I have to tell you it's not. So you'll be able to do that. My assistant here, Hilary, is about to do that. Come on. We'll go back to the same position. Put the cup down. No, you don't hold that. You've got to start from the beginning. And now everyone pay attention because, you're seeing me in the nice stage of my performance. After a while I get really tough.
So, Dr. Vacca,
Yes.
so when you just delivered that baby, you were LOP to start, you found your flexion point, placed it there, and then when you were rotating, baby was rotating to straight OP? Is that
I did then because I wasn't interested in the rotation. But I want some of you to come and have a look from this side. You shouldn't have asked a question. Come up here. Yeah, your question is what, though?
But so it delivered straight OP.
Yeah, I did there then because I was wanting to make a point of getting it on the flexion point. But come up here. Well, I could have said to land and rotate the head to be really impressive, but I'm going to show you something that might... So the head... Come on, Hilary, we put it in that position, and I'm giving maximum deflection there. I can't give any more.
Okay.
Yep.
So it's still a little bit LOP.
A little bit ROP. I'm trying to make it quite a bit
little
ROP.
bit LOP.
A little bit LOP.
And it's a little asymmetric.
Is that an obstetrical term? A little bit LOP? Okay, but no, you're right. No, but don't be afraid. No, you haven't. Get the flexion point.
Right, it's right.
Turn your hand that palmar upwards and lower it a little bit, and tell me exactly how far in you're going to place the cup. Use your other hand for today. Yeah, come out and show us. I'll hold it up. What do you think it is?
It's about 8
Okay, don't stand there admiring your work too long. Pick up your cup. Thumb on the tube in the groove. Yep.
Okay.
Step 2. Take your time. I mean, I don't want you to rush, but I don't want you to waste time. Yeah, look at this. God, it's pretty good. Up with your thumb and out with your hands.
Okay.
Now, the key to the step number 3 is get your left elbow. Good on you. Left with one finger only.
Okay.
That is not. No, don't touch. Oh, you're right. Oh, you're trying to. You are intelligent. Good. Hold that like that. Now, the key is to hold this pose until you finish pumping. Don't go for a walk when you. Can you get this finger? Now, if you have to slide this outer hand, but slide this between your finger and the... No. Finger and top of cup.
Okay.
You got it?
Yeah.
Yeah, but bring that elbow. Keep the mirror images. Now, push with that. The cup should slide in. Is it sliding?
Yep. Sliding
Push
a little bit.
downwards and around. Take your time. There's no rush. Yeah, go on. You're a long way yet. Go on. You're only... No. Don't dig in. As gentle as you can. Push in the midline. Keep going. I'll tell you when you're getting close. Have a look now. Hold it in. Change fingers.
Okay.
Now, who was asking me the question about how do you know? All we're doing is we're working with numbers here. That was you. Oh, that's right. Well, here you go. I was seeing if I could get someone else here. Okay, now look. You're happy that that's 11 centimetres in?
Well, it's 8.
Typical. Well, sorry, you're right. 8. Yeah. I was just testing you. Okay, hold that. Don't move.
Okay.
You're 8. Well, don't stand there. Pump, woman.
Okay.
Yeah. Pump. Now, here's the thing. You're right. 2 fingers either side. Keep your hand where it is. No, let go. Keep your hand where it is and turn.
Okay. And then I can see it.
Yeah, but 2 fingers either side. Why? Because if you put 1 and 3, this finger goes awfully close to the vacuum release valve. And, you might... And the reason I keep my thumb on the same side as the suction, turn it around as you had it that way. Grip it more, hold it in your hand rather than, well, I'll demonstrate. If you do that and you get excited, your thumb falls on there. So if you hold it in your fingertips, 2 fingers either side of the midline thing, and your thumb on the same side as that, you're going to be out of danger. All right, pump, pump, pump. Yeah, it's a bit dry. We've been doing too much talking, but that's okay. The other thing about the model won't rotate if you don't have enough lubricant, and we're a bit dry here. But we say, that's it. Well, you keep going. I can't blame the devices because we've got the manufacturers here, and they won't bring... No, that'll do. Okay, now, check for maternal tissue. You don't have to kneel down until a contraction... Whoa! You're hurting me, doctor. Yeah, what I'm saying is just check. You just check where you can. Don't try to feel behind. Just go. We all want to do it. Now, take your hands out because you're going in with... No, not on the uterus. There's no contraction there yet. Okay. You want to go in with these two fingers, your thumb and forefinger. Okay, kneel down first. Look, I can see that. We'll change cups. Yeah, it shouldn't. Okay. Now you can see. Well, do that with your knuckles. Bunch up your hand like that. Just I want to show you something. Bunch up your hand. Get rid of these. Now try to do that with your hand. You can't, can you? Spread these three. You see, it's just there's a reason for my madness. Now, look, see, you're grabbing just fingertips. Okay. Now, your direction is downwards. Keep an eye on that. If you see that coming out, it's coming out further. Okay, here's a contraction. Now, you were going to come up here. You're going to watch this. Faster! We haven't got time. Now, it's LOP, right? Mm-hmm. Now, I'm just keeping it flexed. Just you pull down towards the floor. Look at the head. Look at the deflection is corrected. Downwards towards the floor. Don't be in a hurry to get up. I can see that coming up, yeah. Well, this is really challenging you, so, Okay, just pull now. So if I just keep that head flexed, keep going, slowly. And if I just keep that head, keep going downward, yeah, the contraction's still there. As it hits the pelvic floor, it'll start to rotate. You can see it rotating. The groove will start to move across. Okay, keep coming. Well, if it pops off, we'll send it, look at it, as it hits the pelvic floor. But you've got to keep it rotated. Well, at this stage, you more or less give it a few more pumps. That's a bit of a nuisance, but we'll send that back to the manufacturers and say it's not good. See the groove coming around? Now, a lot of the rotation is going to occur. It's good, isn't it? As it hits the pelvic floor. Okay, keep going now, slowly. Ask someone, you've got to think about episiotomy or come up slightly. Here you've got to come up more than you would. Now, your thumb will control the descent. Whoops, yeah, keep your thumb around here. You'll see the groove. It'll keep rotating, even here, so control the descent. Don't be in a hurry now. Come on, it'll come. You'll see. I can see it rotating through here. Okay, and that's not bad. Look, don't let me criticize you. You're close enough to the flexion point. That was as much a deflexed OP that we could get, and it does rotate. Now, what was your question? I forgot about it.
I forgot my question.
Well, you said it came out.
I asked about the capit.
Oh, you're the capit. Who asked about the rotation? Oh, jeez, Did you see that? Oh, that's right. That's why you were here. Sorry. Well, anyway, look, I'll give you, you get more than you bargained for when you... Now, look, don't worry. That's, if anything, you've overshot the mark. I dare you to do that in real life. Okay. So if you do that now, the problem is we don't go any, as you say, if we don't maneuver it the way you did, we end up on the parietal bone and over the capit. So what you've got to do is get behind the capit. Who's next? You should be knocking each other over to come up here. Come on, my little capit friend, come up here. What's your name?
Amy.
Amy? Good on you, Amy. Come on. And now, that was an LOP position. We are now going to do something other than an LOP position, but I want you to use the same technique. Are there any other questions? Come on, I promise I won't ask you if you ask a question. Is that making sense for you, though?
Yeah,
the real capit is only a problem, and I mean it's a little bit different from
the flexion point is not where the capit is.
Yeah, well, yeah, except when it's the only time that in an OA position is that the flexion point is the most dependent part of the baby's head. So, now what do we do this time just to make it interesting, But it's the same thing, so everyone assumes that we're going to make it all.
So, when the first one you did, it came out OP.
Yeah,
but it usually
because,
doesn't.
where's Landon? I'm not going to give secrets away and tell him what he didn't do was keep that head flexed for me, and
Right.
I charge extra for that, you know, and I'm not going to give all my secrets away. But
Right.
what you saw what I did. So those of you who are looking, just so and get me the position and then get me the flexion point. You just carry on while I chat to my audience back here. All the force is this way now, so I'm holding the head steady in that position, because if I just let go, the head would shoot up here with the lubricant. And when we start pulling, all I do is put one finger in the got the posterior fontanelle?
Mm-hmm.
Put your middle finger on the posterior fontanelle. The length of your fingers is about 10 and 5, right? Believe me.
Thereabout, I believe.
Good.
Okay.
Not many people do, but still, that's okay. It's a first. Put your middle finger on the flexion point. You can feel the little rub. Okay, now supinate your hand, palmar surface upwards. Hold it there and lower it not too much, just so that it's on the perineum. Now, there's 10, bang. If you went forward a bit, put your other finger on where it's hitting
Right
the
at the perineum.
perineum and come out and have a quick look. Okay, what do you think that is?
8.
Okay. Well, I'm holding it with... Yeah, good. So, with what's the position, by the way? You're going to share that secret with us? What's under the symphysis pubis? Hey, don't. Come on. Who laughed then? It'll be your turn next. He did he?
The ear's under the symphysis.
Yes?
It's OT.
OT. Wait, left or right?
L. Left. Right.
Right, good. It had to be one of the two. Okay, so it's LOT, and I'm
So
giving you
that's
as
why-
much
that's going
as
anterior, so
asynclitism.
that's why it was.
Yeah,
Okay,
okay.
so it's on
Yeah.
the side.
It's ROT,
Right.
and with as much
this is
asynclitism as I
this
can
is
muster.
further out, by the
Okay.
way.
No, it's okay. Well,
Okay.
I would have said what you just said, 8, because at the same station, I'm giving you as more OTs. Probably would be a bit less in most transverse cases, but let's go 8. Don't be afraid. Pick up your... Which is the one that... Well, let's try that one. Okay, try that one and see. No, use the hand that you've got. Take your hand out. Once you get that, let me... Seeing as you're being very good and everyone else is... You know, when I come back, I'll keep all your names. I'll know who's who. So I'm giving you... Right, now, hold... No, you don't have to hold this end of the cup. Just follow me. Hold it like that. Get a good grip. Right. You need this hand. Retract perineum. And I want you to end up with the groove at 12 o'clock. Lift your elbow. No, that way. It's not difficult. Yep, you got it at 12? Okay, let's have a look. Yep, it'll automatically... Well, that's not too bad. You overcompensate. Just do that. Now, right, I've just moved it across to 12. Now, step number 3, get the left elbow facing this gathering here with just your forefinger, index finger. It goes on the baby's head, right? Now, there isn't much room. You've got to sneak your other index finger between your finger, like that, between your finger and the top of the cup, right? So you can do it without breaking your finger. Yeah, but now not on the cup, on the top of the cup, right up here. You got it? Push downwards. It could slide with this. Push downwards with this. If there's caput there, under your finger, you compress it.
Okay.
You push downwards. Is it sliding? Follow with this. Push, follow, push, follow. Yeah. Try not to look too much. That's about as far as you'll ever have to go, 8 or 9 centimetres.
I feel like I've gone past it.
What?
I feel like I've gone past
Okay,
it.
well, hold it there. This might be a revelation to you. Hold it there with this finger and take your other hand out. Well, you have. Like, I was hoping you wouldn't, and I was going to say, see, I told you so. Just pull it out a little bit, all right? Go in a bit more now. That's about right. Okay. Okay. Now, hold it there and pump. Don't stand there, as I said, saying, geez, I'm good. 2 fingers over the... No, you're right. Pump. 2 fingers. Pump, pump, pump. As fast as you... Yeah, you don't have to race, but... see if you can get up to the top of the green easier. Yeah, that's better. Maybe we're up here. What's the altitude here? Maybe we can't get to...
That's the problem.
Can we change the coloration of the thing?
For altitude.
Okay, check for maternal tissue. You don't have to squeeze. Once you get there, don't squeeze the pump. You know, let it go out. That's good.
Okay.
Your thumb. That's why I say, check. Take your hand out because you're going with your thumb and finger. A contraction's about to come. Now I'm the uterus, so until I say I'm contracting, I don't want you to pull. Right? Well, I'm about to contract, so get down on one knee. What I want to do, get ready. I want you to get ready. Thumb on the cup, index finger on baby's head. Right?
Yep.
It's hard to do, but now. I want you to... Oh, don't pull yet. I'm not contracting yet. Now, that's the direction. You notice it's transverse arrest, if you like, or deep or transverse position, and we're pulling downwards because I want you to... Don't pull yet. I want you to see... So I take my hand away. Just pull downwards towards the floor. Look at the asynclitism corrected. I mean, you see that, and then now what I'm doing, because all the force is going this way, I just keep a bit of what I call retro resistance. It's a contradiction. Take it. Ooh, geez, you got a good pull there. Just take your time. Yeah, control the descent. It's the other thing for holding it. You can, without looking, tell what's going on. Contraction past. Contraction's past. Ah, good. Let it go, and you can.
It was almost there.
Ah, well, that's because I was too late in getting there. But the other thing is, if I just let go, the head will keep retracting. So I let it retract a bit, and then so it does need a bit of help from us. Here's another contraction coming now. This is the resistant part of the birth canal. So yeah, gently, and you're right. That's about the right direction. So if you just give a bit of retro resistance as it hits the pelvic floor, don't come up. You're coming up. See it as it hits the pelvic floor. It'll start to come around with a bit of that. Take your time now. You can see it. Yeah, you've got to have some progress, but not too much. Well, this one's not behaving. So it's starting to come around now. Geez, the person is. Keep your thumb there. Ask somebody else to do that. See, it's still coming around. Look. Did you see that? You were the one who was asking about rotation. And I'm not rotating. I'm just giving you a bit of retro resist. Now, hold it up and, well, that's not bad. Blame me. I actually let the head deflex a bit, but you certainly saw the asynclitism corrected. And it came around mainly because we're a bit too far forward. And really, that had to be me letting it deflect, so you can blame me. But you see that even late it came around. Right. You got those movements right, but who's next? Who was laughing loudest here?
Well, he laughed.
Kerry? Oh, so you thought you had to laugh too.
I was not laughing at all.
Now, Amy, this won't look very good in photographs. You better take it off the baby's head before you... Thank you. You know, I mean, thanks. Are there any questions? If you do what you did, but don't be in a hurry. We're all in a hurry, and that's one of the reasons I want to stop you. I could feel you were really going.
But then, to see that it mostly rotates right at the end.
Yeah, a lot of it rotates, and particularly if you have that. This is just reflecting. When we put a pelvic floor in this, we actually built it up from one that wasn't there, from models that don't have pelvic floors. And I have to say, it was a bit scary when my wife, who normally holds this end, the head was rotating most times, and I said, thanks, yeah, don't waste it. No.
We're in an economic crisis.
Yeah, indeed. What's your name?
Carrie.
Kerry? Okay, Kerry. Now, I'm sorry we can't do all of you, but I know the rest of you are paying attention. Now, I am going to show you something. You're going to do two, because I don't want you to feel shortchanged here. We've done an ROT and an LOP with exactly the same technique. Now, you are going to... And no cheating. This is like Slumdog Millionaire. No audience participation here. What's the length of your finger? Whoops. Show me.
Oh.
You got it's 10 centimeters.
And guess what the width is? 3 centimeters.
No, well, yeah, but you can't. I know that, but you can't. You cannot get your fingers in like that. I don't know how people say that. I know. Oh, thank you.
Okay.
But you can only measure that when the baby's out. Don't be confused now. Remember, there are three cardinal positions. We've done a posterior transverse. No prizes for guessing what this might be.
Oh.
Now,
Okay.
ladies, and if there are gentlemen,
So this is,
I want you to look at this, because this. Yeah, you go ahead. Yeah.
this
Where's the
is-
flexion point?
She's ROA.
It is ROA.
Yeah, and she's flexion points.
No, don't know. I want you to use your middle finger. Same technique.
Yep. I feel the flexion point.
Yeah, good. Well, how
Okay.
far is it from the perineum?
It's only 6 centimeters.
Okay, good.
See?
Yeah, good. Yeah, okay, I believe you. Pick up your cup.
Okay.
Did you see what we've said here? I'm pushing the cup, the head right down. It's anterior. And where's my caput? Where's Amy? There's caput right over the flexion point here. You have to imagine it. But it's only 6 centimeters. Well, okay. Hold the cup. You get a good grip.
Got a good grip.
Yep, like that.
Okay.
Yeah, but this way. Two fingers.
Two fingers down.
Yep. In, groove at 12 o'clock. This is ROA. Put the groove. You'll get used to it. It just falls there. Now, let it go. Don't stand there fiddling too much.
Okay.
You got it? It just does it. Take your hands out. So the reason I get people to take their hands out between steps, because you're going with different fingers. Now, Yes. Now you're not going in too far, so don't be too clever. So this elbow stays there. You push it down. No. Where are you pushing? Right on the top of the cup, on the other finger. How are you going to push it down when you're going to the bottom of the cup?
So like
Push down. Yeah. On the. Show me. Right. Right there. Now you're talking.
I swear I have.
Yeah. There's not much room. There's more room in real. Push.
What's this finger supposed to be?
This finger. This finger is on the.
Is on
On the baby's head. Okay.
And where's the other
And the other finger is between the finger and the cup, right on the top of the cup here, because that's the thing that's pushing
so
down.
it's like
Yeah.
this.
Yes. Good. Is it sliding?
Sliding.
Yeah. Go on sliding. You've got to go to the first mark, which is at 6 centimeters. Oh, that's what I wanted to show. Take your hands out. Right. Yeah. Look, this head is low. We said only 6 centimeters, but look where the 6 centimeters is. This is a low anterior. And you still got to go a fair way. You never push the cup anteriorly. Elbow facing the mother. Good. Get used to that because your hand's there, but this stays like that. Just hold that. Look. Let me know. Keep that hand. Stay where you are. Try not to do any damage to you. Now, put your other finger in there. Look, what you do is if you're right there, look, you see you can do that. See how the cup can go in? Now, you don't want to go that far. Okay, let me put some lubricant in. Hold the cup. It's the same technique. How many times have I got to say that?
50.
That's the point I wanted. No, thumb on the other side. Get into the. You see,
So like
yeah. Put 2 fingers. Get a good grip. Don't be afraid. Yeah,
Okay.
good.
2 fingers down here.
Push it up with your thumb and out, woman.
Oh.
See, it automatically falls. Well, when you put it around, it automatically falls there.
Got it.
And the thing is, look, you've got a way to go.
I sure do.
Elbow facing that. See, elbow.
baby's head.
Yep. This one goes on the baby's head, not on the cup. This one is on the top of the cup. Push downwards. It should go fairly easily,
There it
don't you?
is.
Yeah.
Oh, I did it.
Good. Easy. Keep going. You're not even 5 yet. Keep going.
But there's not my there. Okay, there I
Keep
am.
going.
There I am.
Okay, hold it there with your left index finger and pump. Same technique. Sorry if I keep saying the same thing over and over. Keep going. It's a bit dry. I'll just push it up against the head. Well, go to 562. No, that's plenty. Whoa, you're up there.
Okay.
So you've done what others can't do. Check now. This is where you must check for maternal tissue, and you can usually feel round most. There's none there, is it? No, this mother's she's only done 3,000 or 4,000 deliveries. Okay, now take your hand out because you're going, the thumb now is the most important part of you at the moment.
Okay.
And goes on the cup, index finger on baby's head, spread these 3 fingers, and when a contraction comes, I would kneel down. Yeah, don't brace yourself. You look as though you're going to, your knees good? You're a skier, aren't
No.
you? Kneel down. If you want to, it's nothing like skiing, so, okay, your direction with an anterior position, because the head's already anterior and low, is about there, about, it's even less than 45 degrees from the vertical, but that's about right. Now, I do the same thing here. The groove at 12 o'clock on the cup there?
It's like 12:05.
12:05. Well, okay, I believe you. So I do the same here. Pull, slowly. We'll do it in 1. Keep going, because you're not pulling. Well, don't argue with me. I said you're not. Okay. You're right. Thumb on the cup. Yeah, you're right. Yeah. Okay. Now look. Okay, good. If that was a 12:05, look at the groove. Even with an ROA, it's now coming around as you would expect. So it's not just useful for the classical rotational things. Even with an oblique anterior, this is moved. It'll come across to. Well, it should come across if that was. If it was 2 o'clock there, and because you were 5 minutes too late or something, it'll come across this. Keep going. I'm just giving you some retro position. So the head has straightened up, hasn't it? So
sure has.
keep going. You're not pulling. Don't be in a hurry. Yeah, you can obviously come up, but don't be in a hurry. I'm supporting the perineum, and of course you can do anything you like at this stage. Don't let it off. No, leave it there. That's don't do that. It'll come off. Now, what I'm saying is, you said 6 centimetres. I would have probably gone 5, but you can see what happened. We were like that, and if you'd had the groove, there at 12, as the head, it was like so. If the head straightened up, the groove would have come around. But that's okay. But that's still over the flexion point.
Is the center of this supposed to be over deflection.
Yeah, ideally.
Right on.
Ideally. Fortunately, we have got a bit of reserve because I can tell you we often get away with it when we're miles from the flexion point. So, thank you. Now, would you like to do another one now that you know? Okay, because I promised this was anterior and most people feel they're getting shortchanged. But we had to demonstrate that the technique doesn't change. So now we won't, well, we did that one, so why don't we do this one for a change? All right. Let me just see. What's it going to be? A breach.
Better not be breach.
Talking about pulling the head off, well, I was in Italy, and I think you were there, Paul. Remember that doctor? And I was saying he was getting so serious, and I said, "Come on, relax a bit and talk to the woman." And he said, "Madam, I'm going to help you." So he gets down and he pulls the head out, and he says, "Madam, the body will come tomorrow." Certainly putting me in my place. But,
So if this one is again, this is LOA.
LOA. Well, let's make sure it's not LOA.
What?
What's under here again? What's under there?
The ear.
Yeah. You know, I wrote a poem called "It's Always More Posterior Than You Think." So no, seriously, if you say it's LOA, chances are it's LOT, and if you say it's LOT, chances are I'm not. You know, we always want to anteriorize things, and then again, the flexion point is always more posterior than you think. And the third thing is the traction. That's my finger. It's a compound presentation. So you know. Anyway.
Okay.
What is it?
So, okay, then fine.
What's
It's
okay?
LOT.
LOT. Good. Thank you.
But I'm an optimist.
Shh, don't whisper. Okay, come on, don't stand there
Okay.
fiddling.
Okay, so I'm finding my flexion
You
point.
want to find the flexion point, and so I think we've done all
Wow,
the.
that's like a good 8, right?
I don't know. You're the doctor. I'm just a lawyer.
Okay.
Hold the cup like that. You don't have to hold this end of the cup. You
Okay.
need 2 hands.
Okay.
Right. But downwards, put it in. Same technique. Up against the head.
Hands
Out with your hand. Elbow facing the mother. Now, don't put your thumb in. Not yet. Index, get that elbow in the same plane as that.
Okay.
Yep, good. Have you got that?
Okay.
Bit dry, but you should be able to. It should slide okay. Slide in the midline downwards.
Right.
Yep, keep your hand, index. The reason I'm saying get that elbow that way is to keep your index finger in the midline.
Yep.
Is it sliding?
Yeah.
Okay, you measured 8, go 8.
Okay, go 8.
I'm going to look away just to show how much confidence I've got in you.
Go 8. Whoa. Okay.
Well, pump if it's okay. Here we are. Pump, 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 pump. Okay. What altitude are we here?
4,500.
4,700.
Okay, are you my uterus?
Check for maternal tissue.
Oh.
Not there.
No, it's not.
Now take your hand out. Don't fiddle too much. Down. When I did that video, it's amazing how we all fiddle more than necessary. I've actually, if you looked at the unedited version, your fingers are going in and out and so on, and no wonder women complain. Now, what are you doing wrong there? It's a rotational procedure. What's your first direction of pull?
Down.
Yeah, well, so you weren't down, but even more down. That's not down. Now that's down. Now, but look, it looks nicer if you do it like that, and I'm all for the way things look. Now, if we're losing an audience here, but this is all for your benefit. Look, this pull downwards towards the floor. Pull downwards towards the floor. Well, I suppose, yep, that's okay. Now, if I just pull back, come up a bit. Once you get that initial lengthening, whoa, a bit, I said, yep. Okay, keep pulling. Yep, in the midline, gently. Is anything happening? This is what's happening?
My baby's coming.
You're going to have a baby. Oh, that's good to know. What else is happening? I can feel it just by pulling back. It's terrific, isn't it? The groove going? How do you know it's rotating? Don't come up too quickly. Yeah. And we all want to use this extra space up here, but the head still wants to go outwards and not necessarily upwards. At this stage, you can do it slow, but look, take your time. A lot of the rotation will happen, as in real life, when the caput comes out. Here, it's because the head is straightening up, but it does reduce the same thing, and I'll support that for you. And, whether by accident or not, you're over the flexion point. So I'd like to think it was... Anyway, good on you. You got the steps right?
I think I
Don't
do.
leave the
Don't leave it
cup on there
Oh.
because... Now, who's next? Who reckons they're good at this? Because we'll then use this head, which is the same head, but if you've got a. All right, you want to do that one. Not often do you get an opportunity to select the sort of baby and the head you want. And what's your name?
Michelle.
Michelle. Right, you look as though you know what you're doing.
Oh, I don't know. Oh,
And where do you fit into the
I'm a third year also.
third year too? Heavens above. Who's got? Can someone take this tie off? It keeps getting in. It keeps getting into the works. Okay, just pull it off. Oh, geez, you're leaving the. Okay. Do I need that? Is that? All right. Okay. Thank you. How long are your fingers? Show me. Yeah, that's about 10 and a bit. That's all right. 10 and 5. Good. All right, let's make it easy for you, seeing as you got that?
Yeah.
What's yeah?
It's supposed to be easy. It's LOP.
Yes. And? But you haven't told me the most important thing. I give you 30% of the marks for getting position right and 70% for getting me the distance of the flexion point.
And distance to the flexion point, it's like 10 or 11.
10? No, put your middle finger on the flexion. Rarely. You don't have 11 centimetre fingers. How can it possibly be 11? Now, I can tell your knuckles are outside, so it's certainly a bit less than 10, if anything. So,
Oh, okay, that's right. Cause
don't do it from the front, because the marks on the front don't correspond necessarily. There's your knuckle, isn't it? And
Yeah,
that's a couple of centimetres outside. Use your other fingers I'm doing. Run from your knuckle up to the perineum. Don't go in the vagina, but just up to the perineum. Obviously, bang. Come out and show us. Come out and show us. Share your secrets. Yeah, good. We all see that. Good. Don't stand there admiring your fingers. Pick that up. I think that's the... Yeah, that'll do. Hold it like... Good on you. Retract perineum with 2 fingers. Step number 2. Push it up with your thumb. Oh, heavens above. This is pretty good. Try to use 2 index fingers. If the worst comes to the worst, stick another finger in. But try it with 1, because... And in real life... It's no more difficult than this, I can tell you, if you know what you're doing. Hey, so hold it in with this and have a good look. I think you might have gone too far. Whoa, you hold the cup in. It doesn't show me. Whoa, no, you don't look at there. You look from here.
Oh, yeah.
So you are 10 centimetres. So if anything, we should be reflected here. But we may get a surprise. Pump. Pump, pump, pump. You're unlikely to overshoot the mark. Whoa. 2 fingers either side of this. Right. I'm just, can hardly reach it. Right. Oh, I think we might have overshot the mark, but sometimes it's not as far in as you think. All right, I'll give you more. Well, too late now. Check for maternal tissue, so you can hardly feel the cup. So that's good. That's okay. Now put your thumb on the cup. Thumb on the cup. Hard to do. Hard to do, isn't it? Yeah. Right. Can you get? Oh, don't pull. I'm not contracting yet. Have you got your thumb on the cup? Yes. Got your index finger on baby's head? Yes. With difficulty, isn't it? Yeah. The other thing is, look how now. That's not the direction of pull. So don't be afraid. That's what you've got to remind yourselves, that you must pull downwards for the... It's really just the flexing of the fingers, because it's not much force. You just flex your fingers. Now, I'm just keeping that head flexed. That's what I'm doing, or deflexed, I should say. Now, what I want you to do, don't be afraid to do... The reason I don't sit is because you tend to pull outwards, even with kneeling, you've got to force yourself. Unfortunately, there's usually all sorts of buckets and paraphernalia here. You're fighting that as well. But anyway, just give us a pull down towards the floor. Look at the head flex. It does that. And when that happens, and you see this lengthen, but there hasn't been much descent. I haven't let the head descend, but you can see it's easy. You can feel this a lot easier now with your index finger when the head flexes. And then you actually start coming up a bit. We're all in a hurry to come up too much. Okay, here's a contraction coming. And I'm pushing like mad. See the head doesn't come around? If you keep the head flexed and give a bit of retro resistance, I call it, because I'm not actually pulling backwards, but it's just a feeling. You keep going. Normally I would stop. We'll do it in 2, but keep your index finger on baby's head. And this, I didn't point out, I did say it, but this finger tends to slide backwards to the midpoint of the head level, and when it's coming out from under the pubic arch, that's when you can, if you want to come up. But Yeah, keep going. So, give it a chance. It's going to keep rotating, isn't it? Look, the groove has gone well away, and I can feel it wants to rotate it. You don't have to move your hand. We all want to do something here, but you just keep doing it. It's your direction of pull. You've got to go outwards as well as upwards, and see it's coming around even now. Look, I can, ask someone else to support the perineum. And at this stage, you can do what you like, but hold it up, because I never give it 10, but I'd have to go close to it, couldn't I? That was as much deflection in an OP position that I could give. Now, hey, let me make my point. We thought we went too far, but we didn't, did we?
But it's on the.
You're not going to do any harm by putting it on the fontanelle. Well, if we take it off, you'll find you're pretty, you are back a little bit, but if you do that, certainly I'll be happy, and most of the babies will be happy. But you're good. You seem to have got them. Like anybody else? No one's got gloves on.